So this is going to be somewhat basic things, just to reiterate the basic things. Okay. Right. So if a patient comes with chest pain, what runs in your mind? So everybody will think of cardiac causes, and it is very rational to think of cardiac causes. So it could be an acute coronary syndrome, it could be dissection, it could be a pulmonary embolism, myocarditis, and of course there are non-cardiac causes of well, no, pneumothorax, or it could be some GI related causes. So out of all these, the most important time sensitive diagnosis to make is acute coronary syndrome, because time is muscle. So the basic classifications, it could be a STEMI or non-STEMI or unstable angina, depending on the cardiac markers. So again, just to reiterate why early diagnosis is important, because you can observe how um, rapidly the extent of myocardial salvage drop within 4 hours time frame. So the earlier, even just half an hour, you can just observe how much muscle we can save, even with the half an hour interval. So it's very important not to miss a STEMI. Right. So this is to give a basic idea about um, the basic ECG. So, the limb leads and the augmented limb leads are in the frontal plane, and the chest leads, traditional chest leads, are in the horizontal plane. So you can extend the chest leads posteriorly, V7 to V9 as well. So this is the basic thing. So if you imagine the heart, so the right ventricle is bit of anterior and close to the the leads, which is close to the midline. So we call it right ventricular precordial leads, mainly the V1, V2, and V3. Then the rest of it, the heart, the apex is exactly placed at the V4. So rest of it would be left precordial chest leads. So the basically the inferior part of the ventricle is faced towards the lead 3, AVF. So these are the inferior chest leads 2, 3, and AVF. So troponin rise around 3 to 4 hours after the injury to the myocardium, and it peaks in 24 hours and it returns to the baseline in a week. So ECG changes appear even before that. That's why it's important to look at the ECG carefully. Right. So the important take-home message I want to give from this lecture is, please preserve the ECGs, because it's very important, and you will realize it in the subsequent slide. So we usually in cardiology wards, we place the ECGs in a drawing book, so in a chronological order, so the ECGs are kept carefully. Maybe at least we are giving a chance. Or else you can just place it in a A4 and take a photocopy, because with time the tracings in the ECG leads fade. So just please make an effort to preserve the ECGs. Uh, so again, a basic guide, everyone knows this. So it's basically the rate, rhythm, axis, and intervals, and QRS. ST wave changes. So always compare the previous ECGs if you have, and correlate with symptoms. So we will move on to the first and foremost important thing, a STEMI. So earlier it was a simple criteria. You just observe for one limb lead or two chest leads, and if there's ST elevation, it's a STEMI. Now it's bit complicated, but it's basically the same. So there should be at least one box ST elevation in contiguous leads, which means the leads which share the same territory. So the inferior, lateral, anterior. So basically it should share the same territory, except the V2 and V3, because there is an ST elevation in normal population, especially young male, in these chest leads. So that's why it's been refined. So in male less than 40 years, you should have at least 2.5 boxes or more ST elevation to diagnose it. If male more than 40, it's two boxes, and if in female it's 1.5 boxes. But basically others the same. So the other condition which is treated as STEMI is left bundle branch block if it is a new onset, or if there are features suggestive of a acute ischemia on top of it, and isolated posterior STEMI in which you won't see any ST elevations in the traditional ECG. Another important thing to look in the ECG are the reciprocal changes, which will help in the diagnosis in case of diagnosis dilemmas. So if you see this diagram, so for the reciprocal changes appear exactly for the opposite side of the ventricle. So and it's basically the mirror image of the QST elevation. So if you see, there are basically two sets of reciprocal changes, right? So if you see the inferior leads, the mirror image, it's the high lateral, right? Just basically the opposite. So the reciprocal changes of the inferior STEMI you will observe in the one AVL high lateral. Likewise, A1 AVL you will observe in the inferior leads. But other than that, if there is a posterior STEMI, you will observe the reciprocal changes in the anterior lead. So these are the only two reciprocal changes you will observe in the ECG, and it's bit sometimes difficult to observe. So you should carefully look for the reciprocal changes. Right. So it would be easier if you know the coronary anatomy uh, when we go on to the next slide. So basically, the left main coronary artery originates from the left coronary cusp and divides into left anterior descending and left circumflex. So this runs in the anterior interventricular groove, and this runs in the uh, AV groove, and the branches it gives on the surface or the epicardium are called diagonal branches. The LAD branches are called diagonal branches. Then the circ branches, these are called obtuse marginal branches, so abbreviated as OM. And right coronary artery starts from the right coronary cusp, and it gives some important branches. So it runs in the AV group and divides into the posterior descending artery and PLV branch. So this is what we call the bifurcation. And in dominant system, right dominant system, which is the 80% of the cases of right dominant system. So the PDA is PDA in both PLV and PDA is supplied by the right coronary artery. This runs in the posterior interventricular groove. Sometimes the circ is dominant, so it dominates and come as PLV, and it gives the PDA branch as well. Sometimes it's co-dominant, so the PLV and PDA are shared by both these arteries. So if you see, this is a right when RV marginal branch. So this supplies most of the right ventricle, and this is a conus branch which supplies the main, which is the main supply for basically the SA node. And there will be another branch coming from here at the bifurcation, which is the AV nodal branch, which supplies, the AV node. So I'm sorry. Um, So, so the territories of STEMI. So, anterior STEMI means that the LAD has gone. Sometimes it could be a dominant or prominent diagonal branch, but most of the times it's LAD. And inferior, it could be right coronary artery or the circ, depending on which dominant system it is. All the others, the high lateral and the lateral, maybe an OM circ branch or a diagonal branch. Right, so we'll move on to the ECGs. So again, a straightforward ECG. So in ST elevations in inferior leads. So if you carefully look at the 1 and AVL, you can see the reciprocal, so-called reciprocal changes, right? Right. So so this is extending now. Sometimes, ECGs can tell the location of the block. So if the ST elevation in 3 is more than 2, then it means the block is somewhat proximal rather than mid or distal RCA lesion or the block. So again, an inferior STEMI, and you could see the reciprocal changes, and on top of that you could see the mirror image or the reciprocal changes in the anterior lead. So this is an inferior STEMI with posterior extension. And again, the ST elevations are more in tree, and there is RV infarction. So which means definitely the obstruction is proximal, because the RV branch starts somewhere mid in the right coronary artery, and the tree is more. So this is bit of a proximal obstruction of RCA. So in the traditional, the 12 lead ECG, it may be difficult to recognize the RV infarction. Sometimes it may give a clue. Sometimes there will be an ST elevation in V1 and ST depression in V2, which is basically the paradoxical thing. So if you observe an ST elevation in V1 and ST depression in V2 in maybe an associated inferior STEMI, then it may indicate that there is an RV infarction as well. So if you take the right-sided leads, then it will give the diagnosis. So basically, the right-sided leads are just the mirror image or of the left-sided chest lead. So same locations, but it's placed in the right side. So V1 and V2 are already there, so it is switched. Otherwise, it's V3R, V4R, and V5, V5, V6. Okay. So here you can see that the right leads have been taken, and it shows the ST elevation. So this is clear inferior STEMI and associated RV infarction. And you can see obviously the reciprocal changes as well. So why it is important to recognize an RV infarction? So if a patient comes with inferior STEMI, you see clear lungs, you hear clear lungs, and the blood pressure is low. So if you see an RV infarction, then yep, you have no doubts, and you be confident to give more fluids, and you don't have to call the cardiology team or your seniors to do that. So that's why it's important to recognize the RV infarction.